if we look back here, you can really kind of appreciate that defect if we come in from the occlusal, Dr. Sanchez. You can see that there's space if I put my probe right at the adjacent. Yeah, can you all see the space right there? And another big thing that I'm looking at is I'm looking at the keratinized gingiva that's around. We can see this really nice band of keratinized gingiva that she has on the adjacent teeth. This is exactly what I do for patients, is I take a probe like this and I show them how we can move this tissue, but we can't move this tissue. So we've got this nice seal here. And as we go towards the edentulous area, we can start to see that seal goes away. So we've got a bit more mucosal tissue as it makes kind of a V into here. So what does that tell me? It tells me we're lacking a little bit. So we're gonna have to do our best to maybe not augment it, but we can find tissue from elsewhere and move it. So when it comes to my incision design, I can actually make my incision a little bit more lingual into the keratinized gingiva. If I make my incision kind of here in this area, a bit more lingual, can you all see where I'm touching? And if I make it here, I'll reflect this keratinized gingiva buccal, and I'll be able to reflect a little bit more to the lingual as well. So if we go nice and slow all the way across, what I'm doing is I'm taking my 15 blade and I'm feeling, make sure that there are no dips or concavities in there. So slowly going across. I had a professor once tell me that when reflecting a flap, know that all that periosteum, that belongs to the flap here. You can see well. So I'm gonna retrace. Just make sure before I start to do my full thickness. So what I'm doing now is I'm taking this Moltz elevator and I'm very carefully releasing that periosteum from off the bone. Very carefully. So going all around. Slow, and like I said, that periosteum belongs to the flap. So very carefully going around. Little tiny bits, want to try to get it off. As we work our way apically, we can start to really visualize that defect as well. This soft tissue is pretty thick actually. It's 2-3 millimeters thick. We could actually measure it here. Or we can actually measure it like this. So we've got about 3 millimeters of thickness. So this is good thick tissue here. So if we're going for zero bone loss concepts, then we're gonna want 4 millimeters, right, from the implant to that soft tissue. So maybe we wanted a millimeter crestal, subcrestal. So now we can really kind of visualize the defect in the area. We have a nice full thickness flap ready for our implant. So that's exactly what we're seeing in the CBCT. That is what we're seeing here. See how it pops on. So you want to make sure it's seated down. You want to get here. So ensuring that it's seated the whole way. As we go through drills number 1, 3, 5, and if we determine that bone is dense, we can go to these dense bone drills. Do we think this bone is going to be dense? Probably. It's posterior maxilla. She's missing a tooth for a while. We can see on that CBCT that she's got. Yeah, these guides tend to move just a little bit unless they're actually tacked in. So usually what I'll do, I'll either hold a portion of it or have the assistant hold a portion of it. Line it up, make sure we're passive, and then it just goes to depth. There's an in and out motion here. Great. It's hard to see.
That's good. I can see perfect.
So what is that showing me? That shows me that it's kind of where we planned it. Fairly buccal right there. We want 2 millimeters. Yeah, fairly buccal. What's on this guy? There's a piece of floss hanging off of it, see? Because what this is just a little pin that I'm gonna take over here. I'm gonna put it right into our pilot hole in the back of the mouth. And here I can do a couple things. One, I can look. I can just visualize and see where we are. see if we're along the central groove. And one more thing, muy suave, is I can see approximately, perfecto, when she's closing down right there, where is she closing? She's closing right on that palatal cusp of number 15 there. Gracias. So, all right. So is this approximately the plan that we had with our Blue Sky Bio software?
Yes.
This is definitely the plan. Nice job, Dr. Romero. Right here, turn it like that. There's a little indentation right at the apical aspect of that. And that right there allows for better seating into your previous osteotomy. And it should kind of pop right in there. Now, since we're not doing things fully guided today, I still have to watch my drill, see where I'm going. So what I'm doing is I'm watching my angulation both buccolingually, and I'm watching my angulation mesiodistally. It's going to want to fall right into our osteotomy, but still I can push it one direction or another. Where is it going to want to go? It's going to want to go buccal because there's no bone there. So we'll just very slowly and carefully start going down. And I'm actually going to end up using the longer one to get down there better. You're lucky to have a good patient like this. So it falls right into our osteotomy there. And it goes all the way down to depth. Yes? So the depth is actually in the lingual bone. Because the buccal, so we planned on there being perhaps a lingual, or excuse me, a buccal dehiscence. Okay. So we're gonna go one more drill there, guys.
You only got 25 minutes.
Great. I'm gonna take the shorter drill and we're just gonna look. I'm gonna put it straight into the osteotomy and we're gonna look. So if I put that drill straight into the osteotomy, what can we see? What can we tell? Well, we can tell that I like the buccolingual angulation. The mesiodistal angulation is nice as well. But based on the, can you go a little bit more this way, Dr. Sanchez? It gives you a better idea of the buccolingual. Based on the hardness of bone, I think we're actually going to have to use dense bone drills. So that's to depth, that looks good, but I feel our implant's going to be too hard. We set the B drill, this is for the coronal aspect here. You can go down all the way. So we're just going to line it up. It falls right into our osteotomy, right where we planned it. Giving me quite a bit of resistance, actually. So I'm actually going to take this one step further. And in the Astra kit, the very last line of drills is for the dense bone. So I'm going to go all the way to the dense bone drill. Falls right in. Perfect. Great. When we're looking, if you guys can see right there, there is definitely going to be a defect on the buccal. Not huge, but there's definitely going to be a defect on the buccal because as we place that implant to depth on the palatal, it should be to depth on the buccal, or the mesial and distal as well. We're going to have a slight dehiscence. So never fear, we know what to do with that. So the Astra implant actually only fit in a certain way in the driver. The one thing you want to do is you want to make sure it is not falling out. And anytime you're moving this, you always want something under it. You don't want it to all of a sudden fall where it shouldn't go. But I'm still going to do my best to look at it from both buccolingual and mesiodistal just to make sure it goes down all the way. It's going down. I like the angulation. Going. Perfect. Great. Right at the top, having it engaged, and can you see the torque right there, Angel? So we have good torque there, somewhere around 40 Newton centimeters before it goes. Around 40 Newton centimeters. Okay, so coming from the buckle, what are we seeing? Well, I noticed a couple of things. One, I noticed, yes, we do have a dehiscence. Pretty small, 1 to 2 millimeter dehiscence. If we look, it is countersunk. It is countersunk. And I can tell how thin this bone is as we go a little bit more to the apical. So that's exactly what we're seeing in the CBCT. So regardless, I would love to build this tissue out here. This is because this is not just a soft tissue defect, this is a hard and soft tissue defect, I'm gonna opt to place a xenograft with a membrane. If this was just a soft tissue defect, this is a good indication for putting something like a connective tissue graft or a fiber guide to bulk out that area. So what I'm going to do is make sure that soft tissue is out of the way. I just need a couple just around. Ready? So I was telling Jimena before, these BioGuides say up on it, on the part that should be up. You can read it, and if you can zoom in on that, it says up, right, pretty good. The biggest issue I tend to have is they get sticky as soon as they touch blood. They tend to get very sticky and they're hard to manipulate. So now that BioGuide membrane is tucked into that palatal or that lingual pouch we've got. So now we've got our buccal area that's bleeding now, by the way, which it wasn't bleeding before, it's bleeding. That makes me feel a little bit better. Now we can actually take some graft. So I'm taking just particulate BioOs here. Nice BioOs. We'll check out the consistency. And like kind of Aldo showed, if I can move it around here and it's not falling off my instrument, it's a good consistency. Maybe that, would you mind? Pack this on the buccal aspect right onto our bleeding points and compress it straight onto the bone. So we know that this is going to resorb a little bit. The BioGuide is tucked in on the lingual. Last thing I have to do is tuck it in over that graft on the buccal. So I'm going to do that with an elevator or my mulch. So just carefully reflecting it. The upside is up here, that's what we want. Just carefully reflecting it over. And there we go. So now what's going to happen is, like I showed with the mobility of that flap, it's probably not going to close all the way. Do I need primary closure? No. But I was giving it a little something something just to help it out. I'm not going to get fancy or anything with the sutures either, because simple interrupted sutures should do a nice job in this area. Do a horizontal mattress suture to try to close it a little bit better, but in this case we're going to get good results by, KISS. Keep it simple, stupid. This is 4.0 chromic gut. Okay, simple interrupted sutures here. Clean it all off. See there? So, it's closed. It's not that overlapping praying hands type closure, but that's closed well enough there. Am I anticipating tons of swelling? No, I'm not anticipating tons of swelling with that, but it could. It certainly could anytime you add something. On the radiographs, you can see that countersink. You can see how that's approximately 1 millimeter below the crest of tissue. So what did we say? That tissue was That tissue was about 3 millimeters thick. Planned it about a millimeter subcrestal there using our zero bone loss concepts.